I'll be looking at the rationale for universal birth testing of all HIV-exposed infants in South Africa, the challenges that we anticipated prior to implementation and received, and the one-year results. The program started in June of 2015 with respect to birth testing coverage and in utero transmission rates. And then to look at next steps to keep improving the program. So the rationale for birth testing was essentially that testing at 6 weeks of age was too late to prevent morbidity, mortality, and loss to follow-up in about 20% of perinatally infected infants in our setting. That's 1 in 5. We also have a high PMTCT coverage rate, which means that the proportion of in utero to intrapartum transmission is increased and can be as high as 3 to 1, meaning that in utero transmission, because it can be detected at birth, a birth PCR in this setting detects far more infections than it used to when we had no PMTCT. We also have a captive population of HIV-exposed neonates, in that more than 90% of our deliveries occur in maternity units, and we've recently introduced a recommendation for maternal HIV testing to happen at delivery. So assuming these are implemented, that means we identify virtually all HIV-exposed neonates for testing without having to re-identify them when they come back at their 6-week visit. So the anticipated challenges was firstly the fear of reversing the gains of our 6-week EID program, the requirement for a second HIV PCR to detect intrapartum infections, which we're doing at 10 weeks, the fact that we were introducing this new test to a new location and new staff and would require a lot of training, not to mention adding to their workload, and the biggest headache, the fact that testing and result receipt were going to happen in 2 different facilities, and that we needed new models for linkage to care. So the national birth testing coverage is calculated with a denominator of registered live births multiplied by the antenatal maternal seroprevalence rate. And then the numerator is the number of tests that are done in that age group. So if you follow the blue line from June 2015, that's testing happening in the first 6 days of life. And you can see we came off quite a high base of 39%, and that was because we'd introduced targeted birth testing prior to June 2015, and this province, KwaZulu-Natal, couldn't contain their excitement and had already started 3 months prior to the national program. But it has gone from 39% to above 80% within a year, which was surprisingly fast, I thought. At the same time, the 6-week testing has declined to 19%. The problem is that when you look at testing after birth, so between 7 days and 3 months, the testing there has declined and is lower than the birth testing at just over 60%, and that's a problem. So for the first year, taking from June, when the coverage was only 39%, all the way to the end of that year, South Africa had a birth testing coverage of around 73%. But as you can see, that's not equally distributed throughout the provinces, with KZN being the forerunner. Than 7 days of age, and you can see that we increased from June 2015 from about 8,000 tests per month to about 20,000 by the end of the year. And 20,000 is a rough margin of what we were doing per month at 6 weeks of testing. The transmission rate varies, but overall, for the first year, the in utero transmission rate is around 1.1%, which translates into approximately 200 HIV-infected neonates per month nationally. If we add in the testing, the later testing that's happening between 7 days and about 3 months of age, in the red, you can see we started out at 20,000 tests per month, but we're now under 15,000 tests per month, and as I mentioned, not good enough. The very high percentage positivity that you see in relation to the in utero transmission is certainly not true, because what we have in this group is multiple testing with multiple positive PCRs that we're unable to deduplicate. So very provisionally, on a cohort that we've been following in one health district in this province, the guesstimated percentage positivity in that age group is more like the black line. But we do need to develop ways of deduplicating the data in order to understand which children these are that are being tested later on. So in the first year, that is our picture of where HIV-infected infants are located, with the darker red representing infections in the range of over 200. That's neonates in the total year. And we can zone in on the 52 health districts this way to find hotspots for interventions to improve outcomes and maybe identify additional PMTCT gaps. So what do we need to do to get better? We need to link every HIV-infected neonate to care and assess the outcome of early treatment, considering that that's the whole reason for doing birth testing. There's a lot of training and mentorship that still needs to be done to improve rates of later testing, and that's at 10 weeks and on to 18 months of age and beyond. And also because neonatal treatment is complex. What we really need is some longitudinal surveillance to find out exactly how many infected neonates, infants, children we have. And we hope to do this by introducing either unique identifiers or patient linking algorithms, or both. This will allow us to monitor guideline implementation, for example, whether a confirmatory test is done on a PCR positive patient, and to monitor linkage to and outcomes of care. We are also in the process of evaluating EID point of care testing at birth to see if that could improve retention. Oops. I'd just like to acknowledge my collaborators and UNICEF for funding this work. Thanks very much.